Comprehensive Guide to Lung Auscultation, Anatomy, Landmarks, Placement, and Breath Sounds. Hello everyone, and welcome. In this session, we'll be taking an in-depth look at lung auscultation, focusing on where to listen, what you should hear, and how to differentiate normal breath sounds from abnormal ones. Lung assessment is a foundational skill in nursing and clinical medicine, and mastering it requires a strong understanding of lung anatomy, auscultation landmarks, and sound characteristics. By the end of this lecture, you should feel confident identifying proper stethoscope placement, recognizing normal breath sounds, and distinguishing them from adventitious or abnormal sounds. This knowledge will also prepare you for hands-on patient assessments, where accurate lung auscultation can reveal early signs of respiratory pathology. Learning objectives. The main goals of this lecture are to 1. Understand lung anatomy and how it relates to auscultation. 2. Identify specific auscultation sites using reliable anatomical landmarks. 3. Learn where different lung lobes are best assessed. 4. Recognize normal breath sounds and where they should be heard. 5. Differentiate abnormal breath sounds and understand what they indicate. 6. Apply practical tips to improve sound quality during lung assessment. Overview of lung anatomy for auscultation. Before listening to lung sounds, it's essential to understand what structures lie beneath the chest wall. Auscultation findings only make sense when you know which part of the lung you're assessing. Anterior versus posterior lung assessment. Anterior chest auscultation primarily assesses the upper lobes. Posterior chest auscultation predominantly evaluates the lower lobes. This distribution is important because disease processes often affect different lobes, and missing a region could mean missing a diagnosis. Anatomy of the anterior chest. When examining the front of the chest, you are listening over the right and left lungs, which differ slightly in structure. Right lung. The right lung has 3 lobes: right upper lobe, right middle lobe, right lower lobe. These lobes are separated by 2 fissures. Horizontal fissure separates upper and middle lobes. Oblique fissure separates middle and lower lobes. Left lung. The left lung has only 2 lobes: left upper lobe, left lower lobe. The heart occupies space on the left side of the chest, which explains why there is no middle lobe on the left. Anatomy of the posterior chest. From the posterior view, the lungs are positioned slightly differently relative to surface landmarks. The scapulae, shoulder blades, partially cover the lungs. The spine runs down the midline. The lower lobes make up the majority of lung tissue accessible posteriorly. Importantly, the right middle lobe cannot be adequately assessed from the back. Posterior auscultation focuses on upper and lower lobes, only key vertebral landmarks. C7 to T3 upper lobes, T3 to T10 lower lobes. Internal airway anatomy. Understanding airflow helps explain breath sounds. Air travels through trachea, main bronchi, smaller bronchi, bronchioles, alveolar sacs. Gas exchange occurs in the alveoli, and any disruption along this pathway can alter breath sounds. Preparation and best practices for lung auscultation. Use the diaphragm correctly. Always use the diaphragm, the larger flat side of the stethoscope. Place it directly on the patient's skin. Avoid listening over clothing, as fabric can create false sounds or dampen real ones. Special considerations for female patients. Breast tissue can muffle lung sounds. Ask the patient to lift the breast tissue so you can place the stethoscope beneath it. This ensures accurate assessment of underlying lung fields. Patient positioning. The patient should ideally be sitting upright. This allows access to both anterior and posterior lung fields. For posterior assessment, ask the patient to place arms forward or across the lap. This moves the scapulae laterally, exposing lung tissue breathing instructions for the patient. Ask the patient to breathe slowly and deeply through their mouth. Listen to a full cycle of O inspiration, O expiration. Observe pitch, loudness, duration, symmetry, presence of extra sounds. Be cautious with patients who have respiratory distress. Allow breaks to prevent hyperventilation or dizziness. Systematic approach to auscultation. Always start at the top, apex, and move downward. Compare side to side at each level. Use a consistent pattern. This systematic approach improves accuracy and helps detect asymmetry. Anterior chest auscultation sites. Step 1. Apex of the lungs, located just above the clavicles. Assess both sides. Listen for a full inspiratory and expiratory cycle. Step 2. Second intercostal space, midclavicular line. Key landmark for upper lobes. Compare right and left sides. Step 3. Third intercostal space. Continue assessing upper lobes. Step 4. Fourth intercostal space. Right side, right middle lobe. Left side, still upper lobe. Step 5. Fifth intercostal space. Continue right middle lobe assessment. Step 6. Sixth intercostal space, mid-axillary line. Entry point to lower lobes. Compare bilaterally. Step 7. Seventh intercostal space. Further assessment of lower lobes. Posterior chest auscultation sites. Upper lobes, C7-T3. Begin above the scapula. Place stethoscope between the spine and scapula. Compare sides, lower lobes, T3-T10. Continue downward in small increments. Stay lateral to the spine. Avoid scapular bone. Normal breath sounds. There are 3 types of normal breath sounds, each heard in specific locations. Bronchial breath sounds. Characteristics: high-pitched, loud, expiration longer than inspiration. Location: heard only over the trachea. Anterior neck area. Clinical note: hearing bronchial sounds outside this area is abnormal. Bronchovesicular breath sounds. Characteristics: medium pitch. Inspiration and expiration are equal locations. Anterior, first, second intercostal spaces near the sternum. Posterior, between the scapulae, T3, T4, vesicular breath sounds. Characteristics: low-pitched, soft, and gentle. Inspiration, longer than expiration. Location, peripheral lung fields, most of the anterior and posterior chest. Abnormal, adventitious breath sounds. Abnormal sounds indicate pathology and are classified as continuous, discontinuous, continuous, abnormal breath. Sounds, these last longer than 2 seconds during respiration. High-pitched polyphonic wheezes. Musical, high-pitched, multiple tones, mostly heard during expiration. Associated with airway narrowing, e.g. asthma. Low-pitched monophonic wheezes, single-tone whistle-like, lower pitch, often heard during expiration, suggests obstruction in larger airways. Stridor, very high-pitched, harsh gasping sound, heard during inspiration, indicates upper airway obstruction, medical emergency in many cases. Discontinuous abnormal breath sounds. These are short, non-musical sounds lasting less than 2 seconds. Coarse crackles, low-pitched, wet bubbling sound, heard mainly on inspiration, may extend into expiration, often clears with coughing. Fine crackles, high-pitched, soft crackling sound, heard during inspiration, does not clear with coughing. Common in pulmonary fibrosis or heart failure. Pleural friction rub, low-pitched, harsh grating sound, heard on inspiration and expiration, caused by inflamed pleural layers rubbing together. Differentiation. Tip: ask the patient to hold their breath. If the sound persists, cardiac origin. If it disappears, pulmonary origin. Conclusion: lung auscultation is a critical clinical skill that combines anatomical knowledge, systematic technique, and sound recognition. By understanding where to listen and what to expect, clinicians can detect abnormalities early and guide further evaluation or treatment. Consistent practice, listening to healthy lungs and abnormal examples, will sharpen your skills over time. Always approach lung assessment methodically, compare sides, and integrate findings with the patient's overall clinical picture. Thank you for reviewing this comprehensive guide to lung auscultation. Continue practicing, explore additional learning tools, and build confidence through repetition and real-world application.